The music stops at the appropriate time. We'll get started. Welcome to this afternoon's session on session 8L, just to make sure you're in the correct room, on care pathways. Just a reminder, this is one of the sessions that is live streamed, so when we have questions, we'll have to use a microphone. We have our 6 presenters all here, ready to present, and as time permits, we'll have questions after. If there's challenges with questions during the presentations, you can also send in questions via the app. You can put in comments in the discussion with the app, or you can always catch the presenters after this session as well if you have individual questions. So we will get started. Then our first presenter is Liedewij Bogaert, who will be talking on the infinity loop of healthcare innovation, development of an integrated rehabilitation pathway for spinal surgery through design thinking. And I guess I forgot to introduce myself. I'm Richard Lewanchuk from Canada, and I'll be chairing the session. So Liedewij.
Good afternoon, or evening almost. I'm a medical doctor at the Department of Physical Medicine and Rehabilitation at the University Hospitals of Leuven. So I work closely with the orthopedic surgeons, neurosurgeons, and I'm also doing research with them. And more specifically about rehabilitation after spinal fusion. I don't know how to go to the next slide here. Oh, thanks. So, spinal fusion is one of the most commonly performed orthopedic procedures worldwide. It's just right behind hip replacement that we all know very well. And a lumbar fusion, that's when you do the spinal fusion in the lumbar part of the spine, is when the surgeon puts screws in 2 or more vertebrae to eliminate motion and to eliminate the cause of back pain, which can also irradiate to the leg and give leg pain. Now, we see that after a lumbar fusion surgery, only 62% of patients has less pain. Only 41% of patients has an improved functionality in their activities of daily life, and only 36% of patients return to their work. So there is a problem going on with those lumbar fusion surgeries. We know from the radiographs that we take from the spine that the surgery is almost always successful. It's like 90% that it's a correct fusion. But we know as well that low back pain, which is the main indication for a lumbar fusion, is a multifactorial problem. So we cannot only focus on fixing the spine and not see the patient as a whole. On the other hand, we also know that rehabilitation can improve the outcomes after lumbar fusion surgery, but up to date, there is no consensus in the optimal timing or optimal content of this rehabilitation. So we are in need of an optimal rehabilitation pathway for our patients. We know that there are traditional approaches to develop such a pathway. The problem is that it's a stepwise approach. We look at the evidence, then we build a pathway, and then we will translate it to the clinic. And the problem with that, we all know, is the no-do gap. It doesn't work. So we are in need of a more innovative approach. And design thinking is increasingly embraced in healthcare, like mainly for medical devices, products, not so much for developing pathways. And that's exactly what we wanted to see how we can do that. So it's starting from the user, not from the researcher, but we start with the user in mind, and it's a continuous improving and a continuous testing. So we followed the infinity loop of design thinking, which is a visualization of the Stanford Design School, and I will directly deep dive in each phase with you how we did it for our lumbar fusion patients. First, we emphasized with our patients. We get to know them, we get to know their needs, their desires. And we did it with both quantitative data in a prospective cohort study, where we looked at how are patients doing after usual care. And we also collected qualitative data. We did interviews with both patients as well with all healthcare providers involved. It's like occupational therapists, psychologists, surgeons, physiotherapists, and so on. Then based on the needs and desires that we collected in the previous phase, we can define some user groups. And to put it like more simple, we have the patients on the one hand, and all the providers, like the occupational physiotherapist and so on, in the other hand. And the problem that we need to solve for both user groups is not exactly the same. So that's important that we formulate the right problem to also be able to create a right solution. So for patients, they need a tailored rehabilitation pathway that is also in the pre as well in the peri, during the hospitalization and the postoperative period, and that is provided by an interdisciplinary team. Whereas providers, they need an easy to use that is applicable in their clinical practice, evidence-based, amongst disciplinaries and also across the murals, transmural from first, second, and third line treatments. Then we need the fuel and the source material to build our pathway. And for that, we first looked at the current evidence. We did a meta-analysis of the RCTs available in the literature, and it was clear that an integrated and multimodal rehabilitation pathway has better outcomes than exercise alone or only usual care. But as you see, there was no consensus on the optimal timing or on the optimal contents of that multimodal rehabilitation pathway. So we needed some extra information to build our pathway, and that's why we did a modified Delphi study. We did 4 rounds where we asked experts in the field on statements if they agree or if they not agree. And if 75% of the experts agreed, then it was seen as a consensus that this statement was important to incorporate in an optimal rehabilitation pathway. And this allowed us to build our first prototype. You see, we start preoperatively already, then we have some aspects that are innovative during the hospitalization phase, and we continue until the goals of our patients are reached. Of course, this is the first draft, so we did a lot of meetings in our interdisciplinary task force, but also afterwards in some subgroups, like only the physiotherapists together, only the psychologists together, then like first line. So we had a lot of meetings. And then this final prototype is now tested in the University Hospital of Leuven. We chose for a hybrid type 2 trial because we think it's not only the effectiveness of our pathway, but also the implementability, how it's accepted in the clinical practice, that is important. So for the effectiveness, we use mixed methods. We don't only want to know how they improve, but also why they improve. And the same goes for the implementability. We will quantitatively assess all the constructs of implementability, but we will also do some interviews with patients and focus group with healthcare providers to see what are barriers or facilitators to implement this pathway. And of course, important is that we do this on an iterative manner. By testing, you get to know your users and your solution better so you can refine your pathway. Thanks.
Thank you very much. Are there any questions from the audience? Sarah, we'll get you a microphone.
Thank you, Liedewij. Nice, very nice presentation and very well performed on this big stage. I'm always looking for what could be next. as the title of this conference is a participatory approach. And I'm also already glad that you use interviews and focus group to really assess what's necessary. But during the entire trajectory of developing this, could you, in another year, could you really involve the patients in really the development and the evaluation? And can you say something about that?
Yeah, of course. In each phase, patients were involved. In the first phase, it was through interviews, one-on-one. We had 5 patients in the first phase. After the Delphi study that I commented on, there was also a focus group with 9 patients that underwent a lumbar fusion surgery in the past, where we presented all the statements of the experts, and we just asked them, what do you think about it, how do you feel about it? So we really involved them in like validating those statements. There were some discrepancies between the expert opinion and the patients that we then refined in our prototype. Also, in the prototype, I did go quickly over it because of time issues, but one of the monodisciplinary subgroups was also involving patients. So they had comments on the prototype.
Yeah, nice. Yeah, I'm always looking for co-design. So nice, thank you.
No other questions? Well, there is one question. We have time for one more question from submitted online. How was the realism of resource used taken into account in the design process? So it's how was the realism of resource used taken into account during the design process? I'm not sure I understand.
I'm not sure I understand realism of resource, but I think just the use of resources.
The use of resources, or the availability of resources, maybe.
Mm-hmm. So I admit that I'm quite lucky that I work in a university hospital, so there is room to have discussion groups. We have already interdisciplinary meetings in place, so I use that for a lot of the discussions. And for the rest, there are not so many resources like devices. It's mainly human resources. And we have a lot of thesis students, postdocs. Me, myself, I'm doing my PhD in it, so I'm also one of the human resources.
Okay, thank you very much. Then we'll move on to our next presentation. Next presentation is by Debbie CHIODO, Setting the Stage for Measurement-Based Care, Practical Lessons in the Implementation and Integration of Measurement-Based Care within Youth Wellness Hubs, Ontario. It'll come up.
Thank you, everyone. My name is Deb CHIODO. I'm the Director of Data Management and Evaluation for Youth Wellness Hubs Ontario, and I am here today to talk to you about measurement-based care, and I'm going to also tell you a little bit about Youth Wellness Hubs Ontario as well as integrated youth services. First, I want to acknowledge I have much gratitude and privilege to be here today from Toronto, Canada, but I have a team back home of about 40 people who make up the YHU, which is Youth Wellness Hubs Ontario short-form provincial office that supports the implementation of integrated youth services across the province of Ontario. And I'd also like to acknowledge and show gratitude to thousands of youth and families, researchers, clinicians, service providers, decision makers who have influenced the model of integrated youth services across the province of Ontario, but also throughout Canada. So I think one of the things that's been very clear for me from the opening plenary to the different workshops that I've attended is that there's this common theme, whether we're studying primary care, mental health, substance use services, patients, clients, youth, and families have all said one thing: the services are not meeting their needs, the system is fragmented, services are not evidence-based, and within youth mental health, what we've heard very loud and clear from our youth and our families is that the services are not youth-friendly, they're not in youth-friendly spaces. There are these artificial age barriers where as soon as you turn 18, you move into the adult system. There's these artificial barriers of entry into service. They're not accessible. You have to tell your story 5 or 6 or 7 different times to multiple service providers to get the help you need. And globally, on the stage across the world, we have what is called integrated youth services. So if you're from Ireland, you might know Jigsaw. If you're from Australia, you might know Headspace. If you're from Vancouver, BC, you might know Foundry. In Ontario, we have Youth Wellness Hubs Ontario. And integrated youth services is about bringing together in a collaborative way multi-sectors and multi-providers to deliver services to young people, preferably in one place, but doesn't have to be co-location, in an integrated way. This means when anybody walks into an integrated youth service network, they can receive service for mental health, substance use, primary care, peer support, navigation, education, housing, income, and also well-being drop-in activities, all in an easy, accessible, walk-in manner that emphasizes equity, diversity, inclusion, culturally based services that are evidence-informed to really meet the needs of youth and family in a co-designed, co-delivered way. So Youth Wellness Hubs Ontario, it is Ontario's integrated service network, as well as one of the most established integrated youth services in Canada. It is a service platform and learning health system, which means we take the practice, we convert it to data, we take the data and we convert that to knowledge, and then together in this cyclical fashion, we are constantly learning and continuously improving the quality of care that is delivered to young people in the province through access, measurement, tailored and integrated quality services. There are 22 locations across the province in over 31 different communities. We have Indigenous hubs, Francophone hubs, as well as hubs in rural and different urban and culturally diverse areas. The model is built on 4 evidence-based core components. These are the essential ingredients that we know improve youth outcome in mental health and substance use. These are youth engagement, integrated governance, accessibility, culturally diverse, and integrated service delivery. I don't have time to talk to you about what those are, except for today I'm going to focus on the 6th core component, which is measurement-based care. For those of you in healthcare, measurement-based care has been something a part of your practice for many, many decades. In mental health, and in mental health, for youth mental health, it is much more slower to have been adopted. And what we mean by measurement-based care is that this is the use of standardized assessments, standardized tools at every visit to understand how young people are feeling, symptoms, thinking, behaving on that day of the appointment, using those standardized tools and assessments to better inform your clinical decision-making. So measurement-based care, it's the routine, systematic use of symptom rating scales integrated into everyday practice. And you may say, well, I've been doing this forever. Well, that might be true, but across the system of healthcare or across the system of mental health care, have providers, clinicians been doing this in a standardized, consistent way so that there's integration across everybody using the same measurements, using the same processes, and using the same integrated data platform. And within measurement-based care, it's embedded within a framework of shared decision-making. So throughout this conference, we've heard about goal-oriented care, we've heard about patient-oriented care. This is what measurement-based care is. It really allows the youth or the client to be an active participant in their care, because now you're going to take the data and together in a shared decision-making framework and relationship, you're going to be able to collaboratively come up with a plan of care that meets the needs of the youth and their reasons for being there today. And the good thing about measurement-based care is that it's trans-theoretical or trans-diagnostic. So irregardless of what the young person is presenting with, measurement-based care works to improve outcomes, and irregardless of the approach that you deliver care, whether it's a CBT or DBT approach, it works across a multitude of different approaches to improving health and mental health. I won't tell you about the evidence of over 20 years, mostly on adult populations, mostly in westernized communities and countries. However, randomized control trials have told us many things. Number one, if you implement measurement-based care in your practice, you will see significant improvement in youth outcomes compared to usual care. Number two, you'll see a decreased likelihood of youth deterioration. So a lot of times in clinical practice, you can get what is called clinical inertia. You're not seeing improvement in the patient, but you're not actually changing the course of direction, and you kind of get stagnant. That happens to everyone. Measurement-based care forces you, because you're empirically monitoring progress over time, to really change the course of direction as you see different changes in that young person's trajectory. You're going to get faster improvement, and ultimately it's a decreased cost of care because you don't need as many sessions to see a young person when you're actually monitoring progress. Anything you monitor is going to increase the likelihood that you will change depending on the direction of that monitoring. So I'm going to show you the pathway of implementation within integrated youth services. A young person will come to a hub and walk in and meet somebody at the front door and want to get service. And at that front door, they will measure in a youth-friendly way, giving a tablet, symptoms that we have chosen and symptom rating scales that we have chosen. So the young person does that while they're waiting for an appointment. Everybody has to wait at least 10 to 15 minutes, and the battery of tools allows that. The practitioner, before they actually see the young person, will review the responses prior to the appointment to get a sense of what that young person is experiencing that day. Together in the room, the youth and the provider actually review those responses together to say, hey, it looks like you're feeling really distressed today. Is that what you want to talk about? And then over time, with multiple visits, you'll be able to track some of those things that young person is saying. You're giving the young person a quantifiable way to measure their symptoms that you might not other do through motivational interviewing. That's not really standardized. It's not consistent. And then together, you collaboratively have a plan. And so I'm going to share with you our journey of measurement-based care. We've been implementing measurement-based care in our 22 networks for the last 3.5 years with varied success. And if you read the literature on measurement-based care, you have experience with it, you'll know that the challenges often are quite extensive. And I'm going to share with you some strategies, some challenges, and some adaptations that we've implemented. The first is that if you're going to implement measurement-based care because you care about improving outcomes and it works, prepare for a demanding process of change. Workflows within a clinic, within a hospital, and within a hub will absolutely change. You are now asking service providers to have a standardized assessment that everybody follows. They will already have come in with their own tools, things that they're comfortable with. And now, ahead of the appointment, they've got to review all this data. And then within the session, they have to feel comfortable talking to that young person. And so what we have found that it's really important to set those expectations early about why this work, continuously focusing on the fact that it improves youth outcomes. You need to provide training, coaching, and technical assistance on an ongoing matter. Measurement-based care only works if you have the technological infrastructure to support it. You cannot use paper and pencil to do measurement-based care well. And so within an integrated data platform, that allows you to collect that information in a really easy, timely way. That is another kind of change process and change management process that the clinicians have to adjust to. Measurement-based care is demanding. It's going to be met with some resistance. Now that you're actually monitoring how well your clients or youth are doing throughout session, there's a feeling from service providers that they will be evaluated. And so that apprehension can actually get in the way. And so you have to deal with those challenges as you go along. Leadership is essential. We have found in our hubs, if the executive director or the manager or the person at the top actually doesn't believe in measurement-based care and it rests solely on the shoulders of the providers and the clinicians, it doesn't actually work very well. When leadership can bring the measurement-based care findings to meetings and discuss those as a team, that actually improves the implementation of the measurement-based care. And when the leadership actually shows that, it's okay if young people aren't doing well. They have very, difficult, complex lives. It's not that every intervention is going to get them better immediately. And so looking at those failing cases, in quotations, as opportunities to learn how we can do better is really important to facilitate measurement-based care. Another really important lesson we've learned is that you absolutely have to engage the clinical staff because their understanding and willingness to implement this process is key. So if you don't spend that time and resources to engage them in how do we actually collect this information, what tools do you think are best, how is it going to interrupt your workflow, and let's figure out a way in the care pathway that we can implement that. We do formal trainings of measurement-based care in advance of implementation. We give them modules on why it works, how it works. We teach them how to use the integrated data platform. We show them how to use the tools, how to interpret the tools, and we create resources and scripts so clinicians can talk in sessions about why measurement-based care matters and how to have those conversations with young people. And again, if you keep focusing the discussions with clinicians and your team about how it improves outcomes, that actually it resonates with their values because that's what people care about in this field. They care about improving young people's lives. And so that really helps to facilitate the implementation. And on our team, we have an advanced clinical practice lead who works with sites to implement those tools. Another one lesson learned is engaging the animator staff. So in many clinics, you might think of this as the intake person, the person at the front door, the person at the front desk. That person is absolutely key in our model to implement measurement-based care. I say that because as that young person walks through the door and they are told they have to answer a number of questions on a youth-friendly tablet, you have to explain to them, why do you collect this information and who's going to use it and why is it important? So we often say, we're going to ask you a number of questions, but this is really going to help me figure out which service is best for you and which service provider may be best for you. So that conversation happens with that young person right at the beginning, and that's setting the stage for measurement-based care. And they can help assess whether that young person is too much in crisis and you can't collect those tools, or whether they are coming in and English is not their first language and they need support and interpretation, or there's cognitive and neurodiversity in place. So that front person has been really the ears and the eyes and the heart of our hub, as well as the implementation of our measurement-based care model. Of course, there was a workshop here, like nothing with us, without us. Youth engagement is absolutely critical in the model. Youth co-design and have co-designed the model, they co-design the services, they pick the space in their communities, and they pick everything about it. They sit on integrated governance tables, and they determine exactly how the service delivery is going to happen in their community. We engaged youth in the selection of measures. They helped to develop our platform. They also helped to develop the care pathways, what services are available and who offers them. We actually share the data back with youth advisories at the local and provincial level, because you often hear from young people, you're always collecting information from me and you never share it back. And so an important part of that model is to ensure that you share back the data to the people that gave it to you. We use iPads to collect this information. Again, it's easy, it's accessible. Young people love technology, and the youth-friendly welcoming space is sort of what we would call the waiting room. In clinics, you call it the waiting room. We wouldn't call that in integrated youth services, because that's not really kind of youth-friendly language. So everyone always asks, what do you measure in integrated youth services? We use a number of brief self-report screening tools that measure anxiety, depression, suicide risk, substance use, distress, and their perception of health and mental health. And there's no one battery of tools that's going to work. We've tested these out. We try to align provincially with what the provincial organizations are collecting so we can understand youth at a province level. We also align with other integrated youth services in Canada as well as globally. So what Headspace and Jigsaw are collecting, we all want to do this so we can get a sort of pan-global Canadian everything perspective on youth mental health. And they're easy to administer. The other lesson learned is the frequency of measurement. We do screening tools at every single visit. There's no one way of understanding how often to do it. We have found that if young people only come for maybe 2 or 4 visits. So if you decide to do it on some other cadence, you may miss multiple measurements. We're ongoing and always trying to improve how often we do this. We get a lot of resistance from service providers to say, young people are not going to want to complete this every visit. And every young person we ask, they are more than willing to complete it. They enjoy completing it, and they want to tell you that story. And we've collected that information from them. A couple more slides. Adapting measurement-based care to virtual services. So this is really, controversial in the literature, but also difficult to implement in real practice. So you have to send the tools ahead of time via email, and it has to be on a secure platform. There's lots of concern that what if someone screens high risk for suicide at home at midnight and nobody's there? So there has to be very clear systems in place that a young person is realizing that no one is reviewing these tools at the moment. There's got to be clear messaging around crisis supports and protocols in place for that. And we've had less success emailing and texting tools to young people, as you can understand. Like, they don't often access, their email, and they're not really happy to do that in advance. But we are working on that because we know virtual service is here to stay. So some future directions, constantly thinking about which core measures work best for young people. You don't want to just always measure symptoms, and that's what we're doing right now. We don't have that much health measures, and we don't have that many strength-based measures. And so that's the feedback we've received from our providers who've said, you've got to do better. Also, most of our understanding of measurement-based care isn't on the perspectives of diverse young people, and so we're working on trying to understand that. And always thinking about quality improvement in a learning health system and how can we do better, and measurement actually allows that. Measurement isn't perfect, but if you don't measure, then it's really hard to understand change. So thank you. And you can connect.
Thanks very much. That's really interesting and exciting. We have time for maybe one quick question, if anybody has a question in the audience. We have one online question. It says, have you implemented the system of change for clinicians if there's no improvement for a period? I'm interpreting the question, what do you do if there's no change using the measurement after? Are there rules after a specific amount of time, things that are done? Is it protocolized or part of the pathway?
Sure. So that happens at a local hub level. So they would look at, over time. We aggregate it at a provincial level, so we wouldn't know at any one, time period exactly, what do we implement for change. But we encourage the hubs to think about, if you're not seeing progress in a young person after the second or third visit, what's the plan of action? We don't prescribe that because that's really kind of locally and contextually really important for them to determine.
Thank you very much. And once again, if you think of questions along the way, you can send them. You can message the presenter directly. You can post the questions in the session. You can add them to the chat, or you can catch the presenter if you're here physically afterwards. We'll move on to the next presentation then. Next presentation is by Richard Coates on the Alfred Health COVID Community Pathway, development of a multidisciplinary, collaborative, and integrated model of care for supporting COVID-positive patients in the community during the COVID-19 pandemic.
Great, thank you very much, and thank you everyone who's come along to this late session today. It's great to have the opportunity to present. So my name's Richard Coates. I'm a general physician. I work at Alfred Health, which is a large public hospital in Melbourne. And today I'm presenting our COVID pathway work, which was a collaboration between the organisations that you can see on the screen. So I'd just like to thank all my colleagues at our partner organisations as well for their contribution to this work. So Australia is a very large country, as most of you probably know, and it has a very small population. And that population is spread across metropolitan, rural, and very remote communities. So obviously, that's a very different context to be providing healthcare in. We also have a federal structure of government, similar to Belgium, with 6 state governments and 2 territory governments. And unfortunately, different tiers of government fund different sectors of the health system. And it's possibly because of this that we have quite a complex healthcare system, for example, without a good integrated healthcare record. So I live in and work in southeast Melbourne, which is a very large metropolitan area with a population of 2.8 million people. There are 3 separate hospital health services, including Alfred Health, but also Monash and Peninsula Health. And those services administer 12 public hospitals. Primary care in our area is the main providers are private general practices, which are federally funded, but there's also a small community health sector which is state-funded and has a social model of care. Unfortunately, there's not a lot of formal collaboration between these organisations in usual practice, and that's what's so different about the model I'm presenting today. So I've done a lot of work over the last few years to try and better work as a hospital service with community providers and try and break down barriers. And these are some of the challenges that we faced even before the COVID pandemic. I'm sure these are familiar to a lot of other contexts. So one is a real limited access to after hours and urgent care options outside of the hospital emergency department. We also have no primary care access to our hospital medical record or vice versa, and rely on things like discharge summaries to be manually sent by fax, for example. The hospital also has barriers for primary care clinicians or other community providers to escalate the care of their patients, so really limited to a slow and not adequately responsive outpatient model or the emergency department. And so many potentially avoidable admissions, even in usual times, relate to these access challenges and difficulties with handovers of care. So during the first major period of community transmission of COVID in Melbourne, which was in 2020, there were additional challenges. So Melbourne went through some of the longest and strictest lockdowns in the world, including enforced isolation with military and police. And so as a result, people in the community had reduced access to usual care, both health and social. There was also an overburdened primary care sector then that was trying to deal with this additional caseload but had a lack of familiarity with telehealth or COVID management. And so as a result, there were limited home care options and a real risk of overwhelming our hospital system. So I think the importance of having a collaborative approach between the hospital system and community providers was recognised by a group in northwest Melbourne who conducted a pilot study. I've got the reference there on the slide. And our pathway that I'm going to present was a local adaptation of this model involving our own stakeholders and adapted for our area. And most other major health services in Victoria went on to create a similar model. So our collaboration involved groups from right across the entire health system, including government, public health agencies, hospitals, community health and general practitioners that were with our primary health network in South East Melbourne, providing a really key liaison role with individual general practices. You can see in the outline there in red, that's our Alfred Health pathway, but it later extended to a collaboration right across all of South East Melbourne with the other organisations there on the screen. So I'll try and explain just broadly how the model of care worked. So the green colour is a low-risk pathway, which is in primary care and community. The yellow colour here is a medium-risk pathway, which was an escalated model of community management that was supported by the health service. And the red is a high-risk pathway, which is equivalent to needing inpatient care. So referrals were received for all positive cases reported to the public health unit in our area, but they could also be made by primary care clinicians, patient could self-refer, and they could be made by the hospital on discharge. And one of our community health partners conducted an initial triage telehealth call with these patients, notified their usual GP. They had access to care through their own GP, but the community health service played a linking role to provide symptom monitoring and additional telehealth to link gaps where their usual GP might not have capacity or be available. Social care was also available in the form of food, medicine, financial support, and another community health service with expertise in these areas provided support for complex psychosocial cases on referral. At Alfred, we provided acute inpatient care, and we also provided the medium risk level of care, which was a hospital and home-led telehealth with some outreach capacity, with the use of remote monitoring equipment and some COVID therapies, including infusions. And we did do some home visits, and the photo there is from a news article of me performing a visit to a patient's house. We utilised digital health tools, and the one that we used was called COVID Monitor, produced by Melbourne group Arden Street Labs. The main problem was we had no shared EMR across the partner organisations, and we also needed something to help to deal with the large volume of triage and management required. So this was a digital health web-based platform. It sent daily SMS symptom surveys to the patients and had an integrated triage tool included. Those tools relied on clinical sort of algorithms that a clinical user group contributed to the ongoing development of, and I was part of one of those. New referrals were directly uploaded by the public health unit or could be added by the team, and then an assessment list appeared as shown here, including the patient's self-reported symptoms, and then assessments could be prioritised based on risk factors and those symptoms. So I'll just present some of our results for the period for which we were using the COVID Monitor platform and have a lot of data. This pathway actually started in September 2020, but Australia had a zero COVID policy and very little community transmission, so we only had 90 referrals in 9 months up until June 2021, and you'll see that change drastically. So this flowchart explains the streaming of patients through the pathway. So we received a total of 175,000 referrals, which is probably somewhere between a third and a quarter of our entire catchment at Alfred. 72,000 very low-risk patients were allocated to a self-care pathway and just received an initial text message with advice. 102,000 entered an active care pathway and received ongoing daily symptom text messages to report their symptoms, of which 41,000 went on to have a telehealth triage assessment based on either the presence of risk factors or concerning symptoms or social concerns. And those people are then allocated into an initial care pathway, as you can see here. The high-risk group of 600 patients were people who were either in hospital or referred to hospital on triage, and then the others were streamed into either a lower risk path, medium risk pathway, depending on their needs. So this proved to be a safe method for recognising deterioration and escalating care. You can see that the clinical team reviewed over 300,000 patient self-reported symptoms and conducted 77,000 clinician assessments. This resulted in over 1,000 escalations across pathways. Importantly, I'll point out that a very small fraction of people that were allocated to low-risk pathway were escalated directly to hospital care, but a large proportion were then escalated to a higher level of home-based care, of which 90% were able to be managed at home without requiring hospitalisation. There were importantly 0 deaths at home under the home monitoring program, and the pathway also responded to over 7,000 social concerns raised through the text message survey, and there were over 400 complex cases where intervention was required for acute mental health concerns or family violence matters and issues like that. So you can see that we had to respond to more or less overwhelming caseload because zero COVID policy in Australia ended rather dramatically with the introduction of the Delta variant, and then the Omicron variant coincided with the withdrawal of all public health measures or restrictive ones. So our referrals went from 5 per day on average to over 1,000 in about 3 to 4 months. In order to modify our model of care and upscale our service, collaboration was absolutely key, and we maintained at least weekly operational meetings across all of those organisations. And we had a daily virtual huddle with the whole multidisciplinary clinical team online so that any concerns could be rapidly escalated, and that really helped to build a resilient team. We're currently conducting a more detailed qualitative analysis of the patient and staff experience, but we actually sent out a text message survey to all of our patients on discharge. Over 18,000 people responded, and I've just included a couple of the results here. One is answers to the question, overall I felt supported by the COVID pathway, and you can see on the visual analogue scale there, overall very positive result on average. And I think that's really important to note that a lot of these patients didn't receive any contact other than text message symptom monitoring, but overall the response was still that they felt supported. And I've included there just a word map from the comments section as well in that survey, with the word thanks coming through very strongly as it appeared in over a third of the comments. So it appeared that this was well received by patients, even though it was put together very quickly, conducted on a very large scale, and was often, it was a virtual model with often light touch. So in conclusion, this was really a groundbreaking collaboration for our local health system. It built trust and lasting relationships and leveraged the strengths of each of our partner organisations, allowed us to do the impossible, not only in responding to this overwhelming clinical task, but in breaking down silos that had existed for a long time. Digital health tools were key to scalability, and they also helped us act as a workaround for existing lack of shared information systems, such as an integrated health record. It also provides a template for a hospital-supported model for community management of vulnerable patients who are at risk of a hospital admission and potentially on a very large scale. And the next step for us locally in Southeast Melbourne in our health service partnership is adapting this model to support the care of people with non-COVID illness, including those who might experience chronic disease exacerbations. So thank you very much for your time.
Thank you. Are there any questions? We have time for one question, one or two quick questions. Are there any questions from the audience? That was, we'll just get you to use the microphone.
I've one question. I mean, you implemented this for your organization now. Is there any way beyond this, or any learning of that going to the province, to the national level, other systems?
The model overall was adapted locally in every sort of major health district in our state, in Victoria. So I think it's got a huge amount of potential, and we recognise that really from the start, because it's a way of working between hospital and community services which is really novel in Victoria, or in Australia. So we're conducting or putting together a pilot at the moment for a winter respiratory monitoring program, so broadening beyond COVID, including things like flu and other viruses. We no longer have the public health referrals, but the idea would be primary care referrals and emergency department referrals. And then the next step beyond that, I think, is a way of having an escalation model for where a primary care provider has a patient who might, for example, have unstable heart failure or diabetes and can escalate them for a high level of care at home through a direct pathway, rather than being stuck in a position of having a referral that may be responded to in weeks' time in outpatients, or the alternative to send them to emergency. So we hope so. It would be a shame if it didn't continue. Yeah.
It was very impressive. One other quick question that was sent online was for this, and I was impressed with this as well, that you identified psychosocial issues as well using the pathway. So the question is, for the psychosocial issues identified, did you expect that those would be unaddressed were it not for the pathway? In other words, did that allow you to identify those?
It's a really good question. Probably not in a lot of cases, I think. We stumbled, earlier on when the case numbers were small, we had a lot more detail of what was happening on the ground, and we stumbled across all sorts of extremely complex situations. For example, people who had fled family violence situations and were staying in emergency accommodation and then needed support and were completely cut off. So that sort of thing, I don't think in a lot of cases would have been responded to in a timely way if we hadn't had this model in place. They also routinely provided food, medicine, financial advice about how to get financial support, and that sort of thing. So I think it was a very strong part of the model. It was something we intended from the start.
Good, thank you.
Okay, thanks.
We'll move on to our next presenter then. Liedewij Bogaert will be talking about we already did that. That's my mistake. Audhild Høyem will be talking about a quality perspective on the ideal of coherent care pathways for patient with complex long-term healthcare needs, a policy document analysis.
Yeah, thank you very much. Now we will move on to the policy level and talk about the pathways from that perspective. And I come from Tromsø, North Norway, work part-time in the university hospital and part-time in the university at the Center for Care Research. And I made this presentation together with my co-authors Everard van der Kemenade and Wilma van der Vlegel-Brouwer. So there is a frequent use of the term patient pathways in Norwegian policy documents, as well as in national guidelines, speak and writing about collaboration between sectors and institutions to express the ideal care. And note that in Norway we use the term patient pathway, not care pathway. The term is, is used in different meanings, and this has consequences for how to understand and evaluate quality in integrated care. Assessment of whether the quality is good enough or not in terms of integration and people-centeredness requires a common understanding of what good quality means when talking about patient pathways. So we present an analysis of how the term patient pathway is used in central Norwegian policy documents, how the meanings of patient pathway resonate with understandings of quality, and if 4 quality paradigms can make sense in clarifying and distinguishing between various understandings of healthcare ideals. Clinical pathways were introduced in the United States in the 1980s to streamline delivery of care, mainly covering intra-hospital logistics in diagnostics and treatment for particular patient groups built on evidence-based medicine. However, the pathway concept is increasingly used in wider contexts for patients with several diagnoses and high complexity in their healthcare needs. Different types of pathway models are relevant depending on the predictability of needs and the agreement between professionals about treatment and services. 3 ideal types of pathway models are presented by the European Pathway Organization. The chain model, pre-planned chains of care or clinical pathways, typically for defined diagnosed groups, is relevant when there is predictability of the healthcare needs and agreement about treatment. With less predictable needs, where care by multidisciplinary professionals needs to be organized, a hub model is relevant. This is frequently used in rehabilitation or palliative care. A web model is appropriate in unpredictable, unstable, complex conditions where incremental problem solving is needed. Hence, different pathway organization is needed for patients in different situations and various settings. Different quality measures are relevant for different models. 4 quality paradigms developed within the context of total quality management have been introduced by Van Kemenade and Harjono and applied to healthcare by Van Kemenade and van der Vlegel-Brouwer as a feasible framework for assessing quality in integrated care. First, a short presentation of the quality paradigms. In the empirical paradigm, quality is about accountability and accuracy according to measurable standards. Quality in the reference paradigm means that success and improvement relates to the use of models or frameworks. In the reflective paradigm, quality cannot be defined, just discussed between professionals. And quality in the emergence paradigm is when new solutions emerge out of the interaction and co-creation of a diverse group of people, including professionals and patients. The model shows how the different paradigms are fitting in different types of circumstances. Epistemic fluency in the core circle means the capacity to understand, switch between, and combine different kinds of knowledge and different ways of knowing about the world. 3 central white papers from Norwegian Department of Health and Care were chosen for analysis. The Coordination Reform, the Primary Health and Care Services of Tomorrow report, and the National Health and Hospital Plan from 2020 to 2023. The Coordination Reform from 2009 is a central policy document in Norway which lays a foundation for the development of the health and care sector. The analysis of the policy document's rhetoric related to the use and meanings of the term patient pathway is conducted in 3 steps. A word search in the documents for the frequency and use of the term. The meaning of patient pathway is interpreted in the context of each paragraph where it's used. And based on the characteristics and values of the 4 quality paradigms, every use and meaning of the term patient pathway, as it appears in the documents, is categorized according to whether it resonates with one or more of the 4 quality paradigms. And the findings. The term patient pathway is used in the studied policy documents to express a variety of healthcare ideals and values. It's used both about the process and the result of service organization, about recommended trajectories, and desirable patient experiences. Additionally, good patient pathways are used as an argument for different types of organization, for the use of technology, patient participation, new financing systems, etc. Patient pathways also used about healthcare, treatment, the period of illness when a patient needs healthcare, or patient experiences or encounters with healthcare in general. The variety of meanings of patient pathway are used both descriptively and normatively, both in the meaning of planned future healthcare processes and about a person's encounters with different healthcare units that can be recognized as a pathway first when you look at it in retrospect. Often it's used simply about logistics or transitions, or other times about fully integrated services. It's both used about generic and diagnosis-based care trajectories, pre-planned and emergent care to express individualized and standardized healthcare, and sometimes it's used about evidence-based care, other times with no references to a common knowledge base. So, based on the descriptions of the 4 quality paradigms, this is how some central pathway understandings can match the quality paradigms. Pathway, in the meaning of a standardized time-task matrix, reflect the empirical paradigm. Integrated care pathways seem to fit into the reference paradigm in this definition. The expected course of events in the care of a patient with a particular condition within a set time scale. The pathway is divided into time intervals during which specific goals and expected progress are defined together with appropriate investigations and treatment. And understanding within the reflective paradigm is this one, a comprehensive, coherent description of one or more patients' contacts with various parts of the healthcare system during a period of illness, which is discussed and reflected on by professionals. And within the emergence paradigm, care is care is co-created by all stakeholders, including the patient themselves. Resources, infrastructure, and processes must allow this process. It could look something like the web model on slide 3. The word search in the documents resulted in a total of 144 uses of the term patient pathway, distributed as shown in this table. The use of related but less frequent words were also registered but not analyzed. Illness trajectory, standard care pathway, treatment pathway, and healthcare pathway. In the coordination reform, the most frequent understandings of patient pathway are in accordance with the reference paradigm, the orange sector, referring to models or frameworks. However, patient pathway is often used in meaning both the organization of services and the patient experience at the same time. And in these cases, it's not specific enough to be categorized to the reference paradigm. Quality must be discussed in the individual case. Consequently, the reflective paradigms, the gray sector on the figure. And the light blue sector is also quite big. This illustrates the cases where patient pathway is used in such a general sense that it cannot be categorized to any of the quality paradigms because it does not indicate anything in terms of planning, timeline, or model. In the primary healthcare report, patient pathways are used less frequently. The reason may be that the concept of pathway is not perceived as so relevant in primary care as in specialized care. Nearly 75% of the times in use, I could not categorize the understanding to any quality paradigm, often because it's used as an argument. Pathways just used as an argument for different initiatives and priorities. In the health and hospital plan, patient pathway is most often used in context referring to developing normative pathway models or as an argument for development and use of technology. After the coordination reform, pathway models with different degrees of standardization have been developed and implemented, and these are now about to change name from standardized care pathways to national patient pathways, towards a more general and unclear meaning. On the opposite side, in a chapter about new financing principles to enhance integrated care, a new concept is introduced. It's a service pathway. It was the first time I encountered this term, and I find it interesting that in this chapter, a more specific term is used, which clarify that the focus is on the services and the organization of the services. So, we explored how the term patient pathway is used in central Norwegian policy documents. It's a captivating concept with positive connotations to planned and process-organized support to the individual patient's own journey through illness, treatment, needs of healthcare. Its use has expanded widely. We looked at how different meanings of patient pathway resonate with different quality paradigms. Patient pathway used in multiple meanings create challenges for professionals and managers when implementing and evaluating different ways of facilitating integrated care. And we conclude that the quality paradigms represent an interesting and relevant framework to distinguish pathway understandings and pathway models in use in policy documents, and also to discuss how quality can be understood, assessed, and measured in different circumstances. And in clinical discussions on how to organize resources and collaboration around diagnostics, treatment, and follow-up processes, the quality paradigms can function as an eye-opener to the importance of identifying and addressing complexity for patients with long-term needs in various health contexts. A more differentiated language would be useful for indicating more clearly the aim we want to achieve, describe, assess, measure, or how and why we need to organize the resources and way of working. A key distinction that would be helpful is between the term patient pathway as used descriptively and normatively, as it is now mixed. And for the cases where a diagnosed specific treatment pathway is not relevant, we need a systematic identification of the unique degrees and dimensions of complexity in patients' needs and resources, as well as of conditions of importance in the relevant healthcare contexts. And finally, we suggest that the quality paradigm approach may be a good entrance point to the discussions on how to address and manage complexity. So thank you for your attention, and here are the references from.
Thank you. We have time for one question from the audience. A question, was the work done in the Norwegian context? I imagine it's applicable internationally, but was it done from the focus of the context of Norway?
I did it from the context of the Norwegian system, because I'm working both in the hospital and in research, and we are looking at, of course, all these challenges of implementing the policy of integrated care, and it really is complex when the same concepts is used in more and more general meaning, and the discussions both between the clinicians and with the management and with policy. But the quality paradigms is it doesn't come from our context. That's my Dutch collaborators that have been using that. So I was thinking that I wanted to try it out. They tried them out to look at the research in integrated care, and it's used in different contexts. So I thought maybe it also could be useful to distinguish between all these meanings, and it could be as I find it when you that clinicians are very they are very dedicated to quality in their work, but when you start talking about complexity models, you see that it becomes very abstract. So that's why I thought maybe this entrance through the quality and discussing ways, how can we understand quality in different contexts when we talk about integrated care and pathways, maybe it could be a place to start.
Thank you. I think you demonstrated it's applicable across systems.
Okay, thank you.
We'll move on to our next presentation then, from Lina Melby, who will be presenting On Track on the care pathway, care coordination, information, and communication needs among Norwegian cancer patients.
Sorry, what shall I push? What button is it? Yeah, thanks. Okay, good afternoon, everyone, and nice to see that some are still here. I am Line Melby, and I come from Norway, same as Audhild. I'm going to present ongoing research, and I'm going now to turn from the policy perspective to the patient perspective in the patient pathway or the care pathway. I'm going to talk about cancer patients' experiences, and then in particular about the information communication needs and needs for coordination during their pathway. So the background for this ongoing study, which I will mention that is funded by the Research Council of Norway. Cancer patient or having cancer has changed, as many of you know, much during the last years. So from being an acute illness, it's now more a complex and long-lasting chronic illness. And that means that cancer patients may have very long-lasting and complex care pathways. It also means that many providers from various organizations and sectors are involved, and it means that the pathway might be highly fragmented. So that means that good communication and also the right amount of information is crucial to then engage and empower patients along their pathway. We also know from before that there are challenges related to information and communication during the pathway and how that should be transferred. So this is a bit messy slide, but I'll just, it provides an overview of the complete project, and you can look at the website later. But it is, it consists of several work packages, and I'm going to now, in this presentation, focus on the one work package that is about the patient. And we have included two patient groups actually in this project. It's cancer. Actually more specific, we're going to look into kidney cancer, but this is an overall of all cancer patients, and MS. And also in this project, we're simultaneously, as we're investigating the patient perspective, we're also looking into the healthcare providers' perspective. And I'm not going into very much detail here, but the outcome of the project will be some kind of framework to help to model patient pathways. So the overall aim of the big pathway study is to gain, to gain knowledge on patients' experiences with and need for information and communication during their cancer pathway. And in this particular presentation, because I had to pick snippets out of the study, then I asked the question, so how do patients and next of kin describe the motivation for taking an active role in the pathway? What kind of information do patients need, and how do they keep overview of all this information that we know, not always flows, but exists in their pathway? So the methods and material, we conducted 3 workshops, digital. It was approximately a year ago, with 35 persons, and they also were sent a follow-up questionnaire with a couple of questions afterwards. This was supplemented with 6 individual interviews because they couldn't participate in the focus groups or workshops. So this was in total 41 study participants. It was 28 patients, and we also wanted to include caregivers because we know they have a very important role for during the pathway. We applied a so-called critical incident technique when we did the workshops. That means that we asked questions about tell us about a very positive experience and tell us about a very negative experience. So that was actually the 2 main questions. And in addition, we also asked them about how do you keep overview of all your information, and do you feel that you get the right amount of information? So that was actually basically the 4 questions. The analysis is ongoing. So you can look at this as a kind of trying out ideas and feedback is most welcome. So what is very clear is that most patients and also many caregivers take an active role in the pathway. And why is that? That is because, this is a quote from one of the participants, if not the patient coordinate, no one else does. It is a bit depressing, but that was the experience. And it's a lot of work coordinating your own health and illness, as this person says. So summarized, what we found during the data collection was that patients and caregivers, and also I must add that some of the participants were both a patient and a caregiver simultaneously, so we can just imagine how much work that is. So what they talked about was that they take an active role in collecting information. That means collecting various types of information from a lot of different sources. They talked about that they have to process information, they have to align uncoordinated information, and they have to do some kind of quality assurance. They also systematize, store information, and document information in, let's say, new ways. And they have to act as the famous messenger, that you pass on information between providers because there aren't any good links between the providers. So before I turn to the findings, I just wanted to have one slide talking a little bit about how the participants keep an overview over their entire pathway and all their contacts with both the healthcare services, also it could be the labor services, social services, and so on. So in Norway, we have this called Helse Norge, which is Health Norway. It's a patient portal where you can access quite a lot of your own information and different pieces of information from hospitals. They talk a lot about that they get many SMS reminders when they're going to appointments. They use different sorts of calendars. It could be both digital calendars and paper-based. Excel sheets are, we heard about that earlier this day, I think, about Excel as the golden something. So that's frequently used. Many people store paper documents in binders and take them under their arm and carry them between providers. Some people write diaries, and that could be both for more psychosocial purposes, but also to keep track on what's happening. Also notes, logbooks, digital and paper-based, and also, of course, the internet is a source for information. So, turning to three main findings. One activity, so to speak, that they talk a lot about that they're doing is, and have to engage very actively in, is practical planning and preparations. So why are they doing this? This is because they need to remember appointments. They have to be prepared for consultations. They want to have an overview of the logistics in the pathway, and it makes them feel more in control. So that you can look at the quote here, and then one caregiver says that we have used this digital platform Health Norway a lot. But with the brain tumor and surgery and everything, there were some cognitive challenges, so I had to keep an overview. So we have made a shared calendar on our phones, and we sat down every week to plot in all appointments. So it's a very good way to do it, but of course it's also a lot of work for these persons. And then the second theme, it's about processing all this clinical information that you obtained. So what's the motivation behind this? Yes, that is to have knowledge about the illness and different treatment options, to remember details that they are talked about in the consultation. Also, it's important to be prepared for consultations and to be able to ask the right questions when you meet your physician or other people, and to have a sense of feeling empowered. So one patient says that I take notes from the consultation and from what I read in my electronic patient record and write out my questions. I'll go through the questions before my next consultation and maybe rewrite them slightly and then bring the questions to the consultation. So the third theme is about systematizing information and documenting information. And so why is that? That is because participants want to have overview of the complete pathway to ensure good information flow between healthcare professionals, aligning different information sources, coordinating information, and overcoming fragmentation. So one of the caregivers said that what was not so good was the follow-up treatment. They were quite happy with the treatment itself. But then with new doctors who had not informed themselves, a lot of repetitions. So I made a binder with copies of everything which I could give to the doctors. I think it was necessary, and the doctors highly appreciated it. So to conclude from what we have done so far is that both patients and next of kin or caregivers take a lot of responsibility for what we can call information work. And so this is, of course, desired in one way, and as it is in accordance with this ideal of an active, empowered patient. But also thinking about this, I think it's also needed to discuss if this role, is it an active choice or is it a consequence of failing healthcare and social system? And we know that they are fragmented, of course. So I think that the important questions to ask is how can we balance the services responsibility and the patient and caregiver's responsibility? Because it's obvious that we want both of them to participate in a good way. And in this particular case, how can then cancer patient and providers work and enact care together? And of course, also because we know that digital solutions is the way to go. So how can information systems or digital solutions contribute to a more goal-oriented approach across providers? So thank you for your attention.
Thank you very much. Again, we have time for one question.
Thank you, Lien, for your presentation. It makes it so clear what's actually sometimes going on. But I wonder why we use the word pathway in this situation, because it seems like we refer the patient to another doctor or service, and they have to coordinate everything. And it reminds me of the presentation, the previous presentation, where we sometimes can't even acknowledge a pathway to a certain quality paradigm. And so why do we use the word pathway if it's just like a bunch of services that a patient has to coordinate themselves?
Yeah, I totally agree with you, and I was actually a bit unfair towards the project because in the overall project we separate between the patient's journey, which is actually the experiences of the patient, and that is a much more open concept, of course, and then the patient pathway, which is a planned sequence of actions. So here, for the sake of simplicity, I just use the word patient pathway, but really it is, we do separate. So when we talk about the empirical reality for the patient or the caregiver, then we talk about the patient journey. Okay. Yeah.
Thank you. We'll move on then to the last presentation by Ingo Meyer, the Dynamo Initiative, Improving Health System Resilience Through Dynamic Modeling of Integrated Health and Care Pathways in Response to Systemic Shocks.
Thank you. Thank you very much. Yeah, I think I can actually relate a bit, especially to what Richard presented from Australia, and to some extent I can also add to the semantic debate, because I guess I'll be coming up with yet another definition of what a pathway can be, although I'm not sure it really fits into the earlier model. So we've all been through the COVID pandemic, and if you are more the glass half empty person, then you know that the pandemic is only one of many potential and actual disasters of very different manufacture, if you so will, that we are facing also, again, globally, and that are challenging basically the health and social care systems as much as anything else in our societies. And so this is what Dynamo is about, this challenge, these disasters that we refer to as systemic shocks to health and care systems, and where, according to our understanding, there is not always systemic planning on how to deal with these systemic shocks. And I assume that your experience in the COVID pandemic was probably similar to what we had in Germany, that especially in the first year, we were flying very much blind and finding our way how to deal with it, and often also rediscovering knowledge that we had earlier when it came to disasters, how to deal with it. So what is the problem that Dynamo is addressing? Threats to the health systems, and then how do we deal with those threats? Not in the moment they are happening. So let me take the example of an earthquake. So an earthquake happens, it's a very short event, and then you have like an immediate follow-up, maybe like disaster relief. And then what comes then? So you have a situation, the earthquake has happened a week ago, and now you have a situation in a region where you say, okay, 5 out of our 6 hospitals are destroyed. 6 out of our 10 social care services are not working anymore, but at the same time I know I have 1,000 older people with chronic conditions, I have 500 oncology patients in treatment. So how do I deal with that situation and make sure that the system functions as good as it can under these conditions? And here we use the concept of a pathway to describe how a system can react to those medium to long-term aftermath of different disaster scenarios. But what Dynamo as a project is about is how do I do the planning? So because what I would like to do is to be prepared in advance, so to have a plan for every conceivable disaster in my drawer, so that I can pull it out when the disaster happens and do not have to fly blind. And Dynamo, as a project, is about developing a software solution to support this kind of cross-sectoral planning for disasters, for systemic shocks. I'm going to say a bit about how Dynamo works as a project towards the end. We are working with partners in Italy, Portugal, Spain, and Greece that have said, okay, we actually want to address this challenge, and who have made a selection of systemic threats that they want to address. So a kind of priority list, if you will. Another pandemic or an epidemic, high service demand coming, for example, from refugees or migrants, antimicrobial resistance, heat waves, but also staff layoffs. A situation, at least in Germany, that we're now experiencing post-COVID is staff shortages, which make a lot of problems for the health and care systems, energy poverty, cyber attacks, and so on and so forth. And basically the idea is to model pathways. How do I deal with those situations in a perspective of several months or maybe 1 to 2 years, so that I will have a plan on how to address them once they happen. And maybe I need to advance a bit and tell you more about the project itself. It's called a pre-commercial procurement activity. So it's not a research project, it's a procurement activity for a situation where you say, okay, I want a digital solution to address this issue, but there is no digital solution on the market, and none seems to be forthcoming. So one way to address this is by doing this kind of pre-commercial procurement, where you're actually going together with suppliers, with IT companies, and develop these solutions in several phases together. And in each phase, it's a competitive process. In each phase, you select some suppliers who best meet your criteria, and then with those suppliers, you go into the next phase. And within those phases, you have a kind of co-design activities where you do a solution design, prototype development, and then in the end, actual field testing. And you end up with 1, 2, 3 suppliers that won each of the phases and delivered the best solutions. So that is what Dynamo is doing as a project funded by the European Commission. And now I'm going back to this because we actually found something at the proposal writing stage that we first didn't believe. There is no software such as this available. There are software tools that address parts of the issue, but software tools that really allow you to plan this kind of scenarios out over several sectors, so over different parts of the health and care systems that allow you to model using data, those are not available. And that is why Dynamo was then ultimately also funded, that we're now trying to develop this. So Dynamo is going to be a planning tool for these systemic shocks. So how would that look like? A region decides we want to work in that way, we want to procure Dynamo for us. First step could be, okay, we scope the issue. What scenario do we want to address? We say cyber attacks is probably our priority one worry at the moment, so we're going to address cyber attacks first. So who needs to be involved in planning how to address the long-term effects of a cyber attack? You assemble that planning group from the different sectors, and then you need to block out the major planning steps. So cyber attack aftermath, we need to find out, okay, what kind of systems could be affected, what kind of systems are how digitized, and what kind of processes, for example, within a hospital depend on a computer system. So you build a rough outline, okay, what would we have to do when all of those systems suddenly are victim of a cyber attack? And then comes a step where I would say Dynamo is very much a kind of data pipeline, data planning tool. Okay, what kind of information do I need? I would want to know, okay, how many people would actually be affected? So if I'm thinking one hospital will be locked down because of the cyber attack, how many patients and what types of patients does the hospital treat within a month, within a year, where I must assume, okay, these patients will then not be able to be treated. So what kind of morbidities? Okay, they have an oncology ward, so I will have a lot of oncology patients. What would I need to do to have those oncology patients treated elsewhere? So I might need data on oncology beds in neighboring regions, for example. So you need to bring the data together and then using those data to have a very hands-on detailed model that links the data with the plan so that you actually then know, okay, I'm talking about on average 50 oncology patients per month, and I know I have 50 oncology beds in the neighboring regions. Then you can stress test this model, these using different scenarios and saying, okay, actually some of the hospitals in the neighboring region have also been victims of the cyber attack. So what do I do now? Do I have to go further out, or do I have to accept that certain patients will not be able to be treated for some time? So you test different scenarios. And then you have this plan in the drawer, basically, and you put it away, or it's stored in the system. And then when the situation actually happens, so when you've had the actual cyber attack, you reactivate the plan within the software and implement it, and then can at the same time monitor it. So you know you planned with 50 oncology patients, but now on the basis of real-life data, you see, okay, it was really 47 at the time. So where do I put those 47 patients in the neighboring hospitals, for example? So that is basically the idea behind it. We are at the very early stage, so the project started early this year. We're going to have a call for tender
by the end of the year in November. So I hope that at the next conference we'll already have some solutions, some solution designs to present and see where we are going, and also have a clearer understanding of what is possible, especially in relation to the data. It will be very interesting because we're currently mapping what kind of data systems would be relevant and what do our regions have available and how well can those be integrated, because other issues like interoperability, for example, of course also play into this kind of planning exercises. So, and then the project is going to end in February 2026. So at ICIC 26, then you're going to have a hopefully product presentation by one or two of our suppliers. Thank you very much.
Thank you very much. Are there any questions from the audience? Unfortunately, the live question and answer part of the, oh, here it is, there's one question that says, do you expect some plans will be the same across different disasters? And does it pick up things that are harder to plan for, such as social capital and resilience, workforce? I had a similar question as well. To what degree, how granular do things have to be, or how generic do you plan for? So do you plan to a certain stage, and then from that point the pathway is developed, so how granular, I guess, do you get?
Yeah. So those things, to my mind, they're not defined within the project yet, because we want to be open towards the suppliers to see what they think they will be able to deliver. In terms of the planning, I mean, when I plan so I'm from Cologne in Germany, so I plan cyber attack scenario for the Cologne hospitals, for example. The idea within Dynamo is that this plan actually goes into an open source library. So if the next region over says, okay, I also want to plan for cyber attacks in hospitals and the surrounding services, they could build on that plan, and then that gives you cyber attack hospital plan version 2, and those things grow and improve over time. So that's part of that. The granularity really is open at this stage, I would say. In terms of what is going to be factored in, social capital, it would be relevant, but I would assume, because there is nothing at this stage available, that we won't be getting into that in the early stages, if even within the project. But I think everything that has to do with staff resources, staff capacity, will be very much at the forefront, because apart from destruction of physical infrastructure, I think anything hindering staff to do their work will be very high, will be a very high priority topic.
Thanks very much. I think that'll be a very useful product. We always think that we're going to plan, and then something happens and we're scrambling, so that will be, I think, very useful. That brings us to the close of our session, so many thanks to the audience for your perseverance, and very great thanks to all of the presenters for very interesting presentations, and every single one of you stuck exactly to time, so thank you for that. So thank you all. That ends today's session and ends the day. So if you're going to the gala banquet, that starts at 7:30, and if not, have a very good evening in Antwerp.